I welcome everyone on behalf of Pediatric Nephrology to this morning's multidisciplinary meet. And we will be discussing a case that has been on a long-term follow-up with us. And she's awaiting a kidney transplant. Initially, we thought that it was a simple case of structural kidney disease. The kidneys were small when she came. But along the way, Dr. Thakurvir will be telling the story that she has the disease that has evolved. And we'll have with us Dr. Nathan from renal transplant, who will be discussing a bit about how access in maintenance hemodialysis kits is a problem. Dr. Anubha from Skin will also help us to come to a diagnosis of what actually this child had, and Dr. Sanjeev from allergy immunology. In fact, allergy immunology was involved with this case from the time that she had presented because she had certain features. So I just wanted to invite Dr. Thakurvir, please come and start.
So good morning everyone. Today we will be discussing this case and discussing about chronic kidney disease, its etiology, complications, management and renal replacement therapy. So we had Miss V, who was born in 2009 in Sirmaur, Himachal Pradesh, to a non-consanguineously married couple via term normal vaginal delivery. She was developmentally normal and apparently well till 10 years of age. She was first admitted with us in August 2019 with complaints of fever for few days which had subsided, followed by vomiting for 15 days, then easy fatigability and decreased urine output for last 3 days. There was no history of any loose stool, cough or rapid breathing, abdominal distension, rash or joint pain, jaundice, any altered sensorium or abnormal body movements. The examination revealed stage 2 hypertension with a height score of -2.34. She had pallor and the rest of the systemic examination was within normal limits. The urine examination revealed 2+ albuminuria. So a working diagnosis of acute and chronic kidney disease versus acute kidney injury was kept. The further workup revealed pancytopenia with deranged renal function tests, hypocalcemia, hyperphosphatemia, and metabolic acidosis with decreased ionized calcium. The ultrasound revealed bilaterally kidney size of 6.3 and 6.1 centimeter. As for her age, a child would have approximate kidney size of 9 centimeter. So both the kidneys were small and shrunken with raised cortical echogenicity, with irregular urinary bladder with wall thickening. She had pleural effusion as well as pericardial effusion. So a diagnosis of chronic kidney disease was considered. So now coming to why did we consider the diagnosis of chronic kidney disease? The definition of CKD basically tells that it has to have a damage to either the structure or function of the kidney, which can be manifested as a glomerular filtration rate of less than 60, calculated by this modified Schwartz formula, like EGFR is 0.413 into height in centimeter divided by serum creatinine. So this gives us an estimated GFR. So if this is less than 60, or we have markers of kidney damage in the form of albuminuria, abnormal sediment as is seen in tubular disorders, or abnormal electrolytes, or we can have evidence of kidney damage structure on histology or imaging. But these have to be present for a period of 3 months to label it as a chronic kidney disease. Our index patient had bilaterally small shrunken kidneys with a GFR way below of 60 value. She had just 4 ml per minute per 1.73 meters square. So now coming to the staging and prognosis, the CKD is staged for glomerular categories as well as based on albuminuria. The glomerular G categories range from G1 to G5 with progressively decreasing renal function and decreasing GFR, and albuminuria from A1 to A3 with progressively increasing albuminuria, that is the protein is being lost in the urine. So based on this we can see the prognostic classification. This is important because say if a patient has a GFR of around 50 which falls in the G3A range with a proteinuria of A1, so then he will fall in the range of this yellow category, that is a moderately increased risk of progression to the next stage. But a similar patient who has a GFR of 50 with A3 proteinuria will fall in the very high risk range for progression of the kidney disease. So our index patient, she had fell somewhere over here. So now coming to the etiology of chronic kidney disease, it can stem basically from anywhere in the kidney and urinary tract. Like most commonly we have the congenital anomalies of the kidney and urinary tract, which have abnormalities leading to the patient going into CKD, or it can stem from the glomerular damage or tubulointerstitial compartment damage or vascular injuries. So non-glomerular causes, they constitute the majority of the cases of CKD. Our index patient, she had no chronic symptoms. There was no history of any previous significant illness. She never had hematuria or any episode of decreased urine output. There were no urinary complaints, no extrarenal abnormalities on the examination, and the ultrasound revealed no hydronephrosis. So a possibility of CACUT with most likely hypodysplasia was kept. So coming to the course, for chronic kidney disease, she was started on maintenance hemodialysis, initially via IJV line. Then a AV fistula was made and a perm cath was put. For hypertension, she was managed with amlodipine and labetalol. And while admitted, she had fever, which was attributed to catheter-related bloodstream infection. All the cultures were negative and she received antibiotics for some time. She had pancytopenia at presentation, the workup for which revealed decreased C3 and ANA, which was 2+ speckled with negative anti-DSDNA. The ferritin, vitamin B12, folate and DCT were normal. And the bone marrow revealed hypocellular marrow with 50 to 60% cellularity with early paratrabecular fibrosis. So it was attributed to either CKD-induced myelofibrosis versus SLE. Then for anemia, the patient received 1 unit PRBC transfusion. IV iron was given along with hemodialysis and she was started on erythropoietin. She had hypovitaminosis D and deficiency and hyperparathyroidism. That was managed with vitamin D, calcium and trocalcitriol. Finally, she was discharged on maintenance hemodialysis with excess being a permacath. So a diagnosis of chronic kidney disease, stage 5, hemodialysis dependent, with etiology being CACUT was kept, with complications of growth failure, hypertension, anemia, mineral bone disease, and metabolic disorder. So coming to the complications of CKD, they can be multiple, starting from growth retardation, hypertension, anemia, mineral bone disease, metabolic acidosis, and RRT-related complications. So we'll be discussing about anemia and mineral bone disease. The anemia in CKD for the patients that we see falls if the patient has a HB of less than 11 to 11.5. And the prevalence, it is highly prevalent with stage 3 patients, around 70% of the patients having anemia, and 87% of stage 4 patients, and almost all the stage 5 patients will have anemia. Coming to the etiology is multifactorial. Basically, CKD is a hyperinflammatory state, so there is decreased excretion of the inflammatory cytokines and markers that are released in the body. So this leads to a chronic inflammation and increased hepcidin level. There is also decreased production of erythropoietin as well as the resistance to the existing erythropoietin. The inflammation, it leads to poor appetite and poor nutrition of the child, with recurrent blood losses in the form of phlebotomy or dialysis-related losses adding to it. And then this leads to increased demands with a decreased GI absorption due to increased hepcidin, and also due to the uremia and the other metabolites that are accumulated, the erythrocyte survival is decreased. So coming to the management of anemia in CKD, we have to target a FHB of 11 with a closed follow-up with iron, ferritin and transferrin saturation. So if the patient does not have anemia and falls in the CKD stage 3 to 5 range, we will start oral iron supplementation at a lower dose, 3 to 4 mg per kg per day. But if the patient has anemia, then he has to be worked out for all these, and whenever we have a transferrin saturation of less than 20 or ferritin reflecting iron stores less than 100, we consider it as iron deficiency and we start the patient on iron supplementation. The iron supplementation is given orally for the patients who are on peritoneal dialysis or are pre-dialysis patients. But for patients who are on hemodialysis, they are given IV iron for the ease of convenience and to avoid the side effects. So at any time, if the patient has a transferrin saturation of more than 20% with ferritin greater than 100 and no other causes are there, then we label it as anemia of chronic disease and we have to start erythropoietin. Our patient, index patient, she was receiving regular IV iron with hemodialysis, and erythropoietin at 300 international unit per kg per week. Now coming to CKD mineral and bone disorder, we label the patient as having CKD mineral and bone disorder whenever the patient has abnormalities of either calcium, phosphate, PTH, FGF23 or vitamin D. Or we can have problems with the bone turnover, mineralization, volume, strength or linear growth. Or there can be extraskeletal calcifications. So basically in CKD what happens is the excretion of the phosphorus is decreased, leading to hyperphosphatemia, which stimulates the production of fibroblast growth factor 23 in the bones, which acts in the body to decrease the PTH production and to inhibit the action of vitamin D. So vitamin D is inhibited, which leads to hypocalcemia. And this hypocalcemia will again stimulate the PTH. So basically, to understand it better, we have a fall in EGFR, which leads to increase in serum phosphorus and subsequently decrease in serum calcium. To counteract this, the body produces more PTH. And this more PTH, again, it achieves a plateau phase. And then again, whenever there is a fall in GFR, which is occurring continuously in the patients, we will have a situation in where a new steady state is achieved every time to restore the serum phosphate to normal at the expense of sustained high PTH levels. So the management of mineral bone disease basically focuses on this hyperphosphatemia. We have to curtail the phosphate intake to less than 80%. We have to use phosphate binders if we have to. And most importantly, we have to look for the dialysis adequacy because phosphate is supposed to be removed in the dialysis. For calcium, we have to supplement calcium to keep it in the normal range. Vitamin D deficiency, if we encounter in these patients, is counteracted by treating with vitamin D for 3 months. And a word about active vitamin D, rocalcitriol that we usually give. They are used if we have a persistently elevated PTH level. And the prerequisites are like the patient should have a vitamin D of more than 30 with a calcium phosphorus product of less than 55 to avoid extraskeletal calcifications. So index patient, she had hypocalcemia. She was given calcium supplementation. She had hyperparathyroidism. She received activated vitamin D for some time to suppress the PTH. And she had hyperphosphatemia, which was taken care of by RRT. RRT like renal replacement therapy. A word about renal replacement therapy. This is the therapy that replaces or substitutes for the normal blood filtering function of the kidney and provides electrolyte and fluid balance as well as the toxin removal functions of the kidney. Basically, it takes over the functions of the kidney. So the ultimate renal replacement therapy that we aim for is transplant with bridging therapies with peritoneal or hemodialysis. The RRT basically is initiated based on the level of GFR and individual factors. With the falling estimated GFR, it is evident that the kidney function is declining. So whenever the eGFR is less than 30, we start educating the patient that there is an impending need for hemodialysis or peritoneal dialysis or transplant in this patient. And below level of 15, we need to consider that starting the RRT. And below a level of 6 to 12, irrespective of everything, we have to start RRT. But there are certain situations in which the patient may be having an eGFR of way above 6 to 12 range, maybe 30s, 40s range. But if they have a persistent refractory hyperphosphatemia, acidosis, hyperkalemia, or they have uremic encephalopathy, hypertensive emergencies, or the patient is having poor growth despite controlling all the measures, then we need to start renal replacement therapy. And the choice of renal replacement therapy is basically patient-based, whether the patient needs a hemodialysis or a peritoneal dialysis, with some salient points with peritoneal dialysis being that it is more conducive for school and social activities. It is done at home. The duration of the therapy can be controlled at home. The timing can be extended to adjust for the school and social activities. It is better for adequate nutrition because the small children, they will be having a liquid-based diet. So the therapy can be conveniently increased at home to improve the removal of the excess fluid that the patient is taking to maintain adequate nutrition. And it has somewhat better preservation of the residual renal function. The decline in renal function is seen to be decreased with use of this peritoneal dialysis. But there is some side effects, like the patient can have a peritoneal membrane failure with prolonged use, leading this method ineffective as a RRT. Other ways, the hemodialysis, it is used whenever the patient is anuric, oligoanuric, the patient is not producing enough urine, and It has totally dependent on the RRT. So this is a better efficient method, and we go for hemodialysis in such patients. But here there is an issue of vascular access for hemodialysis. So the access for hemodialysis, basically it depends whether we are doing an acute hemodialysis or we are planning a chronic dialysis. For acute hemodialysis, we usually use the HD catheter that we commonly see, the percutaneous dual lumen catheter, or we can use a catheter that is tunneled to decrease the risk of infection. That is permacath. And for chronic access, we have arteriovenous fistula and arteriovenous grafts. The arteriovenous fistulas being the modality of choice for chronic hemodialysis. The index patient, she was initially started on a percutaneous dual lumen catheter because she landed in emergency kind of a situation in an IJV catheter. Later, a fistula was created, and pending the maturation of the fistula, which takes around 4 to 5 weeks, she was put a permacath or a tunneled cuffed catheter to undergo dialysis, which we can use till 6 months. Now coming to the course, she had multiple admissions, and in January 2020, she had her second admission with the complaints of swelling of left arm for 5 days. She had no trauma or redness or swelling elsewhere. The examination revealed that there was no bruit over the fistula, and the left radial and ulnar pulses were not well palpable. So a diagnosis of AV fistula thrombosis was made, and she underwent a thrombectomy. Then in August 2020, her third admission, she was admitted with complaints of fever, cough, breathing difficulty, and headache for 1 day. And the examination revealed tachypnea with normal SpO2. And we did a COVID test, and she was positive for COVID, and she had COVID pneumonia as well as COVID pneumonia. And while she was admitted, she had a rash that was diffuse erythematous papular rash. It involved both palms and soles. The workup revealed decreased C3 and ANA, which was 3 plus homogeneous. A skin biopsy was also done, which revealed epidermal thinning and flattening and hyperkeratosis. There was focal basal cell degeneration and evidence of interface activity. The DAEF done was negative. So a possibility of DRESS versus SLE was considered, and she was started on steroids. With this, the complaints resolved. And then again in February 21, she was admitted with complaints of respiratory distress for 20 days. There was no fever, cough, or any joint or rash or joint pain this time. On examination, her left upper arm veins were tortuous and dilated, as we can see in this picture. The heart rate was 128. She had tachypnea, systolic murmur with hyperdynamic apex, with the rest of the examination being within normal limits. So a diagnosis of high flow fistula, and she underwent reduction using distal inflow. For this, I would like to invite Dr. Nathan.
Good morning, everybody. I am Dr. S. Vanjinadan from Department of Renal Transplant Surgery. I'll talk about pediatric AV fistula and in specific to this case. So, arteriovenous fistula, as all you know, is a surgically tailored anastomosis between an artery and vein, following which the vein matures and which can be used for hemodialysis. So, in adults, as such, AV fistula is the preferred type of vascular access for hemodialysis, which the preference may vary in children. The reason being, the fistula has a longer patency and the rates of complications are lower when compared to other modalities of access. So the complications of the AV fistula can include aneurysm, infection, including surgical site infection and the vascular infection, and vascular infection leading to systemic infection also. And distal ischemic steal syndrome, when there is high flow in the fistula, the distal blood flow reduces, causing steal syndrome. And fistula thrombosis, and for the consequence of which is a venous hypertension. So in children, ultimately all the children who are undergoing dialysis may or may not be considered for kidney transplantation. For the current scenario, the AV fistulas in children have not been widely accepted. Most of the children either have a CAPD or a tunnel catheter. So the issues of AV fistula are these. First of all, there are technical difficulties in forming AV fistulas. It needs expertise, surgical expertise. The artery and vein are smaller in size, and it's not everyone's work to do a pediatric AV fistula. And initiating a dialysis in such a fistula will need dialysis expertise, which again is not common. One more issue is the patient concerns. Children do not usually tolerate pain, so there is concerns regarding puncture pain. Then, if at all any complication arises, maybe bleeding or thrombosis, or the fistula turns out to be a high flow fistula, there is paucity of experience which is not available everywhere. And obviously there is reluctance in considering the AV fistula for children with ESRD. But the advantages of AV fistula are better quality dialysis. The infection rate in fistula is very less compared to a patient who has a catheter for dialysis. And if a fistula is successful, then there are very less chances to change the access. And the hospitalization rate is very less with a functioning AV fistula. So for this index case, after the patient was started on dialysis using a catheter, the patient came to us for fistula creation. So after the initial assessment in March 2019, patient underwent a left brachiocephalic fistula. Our plan was initially to, whenever the patient comes to us, our plan is always to make a fistula as distally as possible. So the most distal option is a radiocephalic fistula. But in the children, we always prefer a brachiocephalic fistula because the radial arteria size is very less. And so the brachiocephalic fistula was made. Following which the fistula became functional. And it was working well for almost a year. Then the patient came to us in Jan 2020 with thrombosis of the left brachiocephalic fistula. After assessment and planning, patient underwent a BCF thrombectomy. But following this thrombectomy, the patient again developed a rethrombosis, but that thrombosis was not complete. It was a partial thrombosis. So in view of partial thrombosis, the venous collaterals in the upper limb opened up, and the blood flow was redirected in all the collaterals. So the patient's fistula was still patent irrespective of the thrombosis. So due to this high flow fistula, the patient had again features of overload, and in March 2021, patients underwent a procedure which we call it as RUDI, revision using distal inflow. So the problem was with this patient in specific was when the BCF was made, it was a high flow fistula. When you have a high flow fistula, the shearing stress caused by the high blood flow, the turbulent blood flow, it causes endothelial injury. So following endothelial injury, there is venous intimal hyperplasia, which caused a central venous stenosis in this patient. So following the central venous stenosis, it ultimately leads to thrombosis. And when the thrombosis is not complete, in this case, initially it was complete. After thrombectomy, a patient again developed a recurrent partial thrombosis. So due to this partial thrombosis, the part of the vein which was distal to the thrombosis was patent, and the multiple collaterals arising from that vein began to take up the blood flow. So there was extensive collateralization in this patient, which maintained the fistula patent. So post-procedure, after the patient had rethrombosis, we planned for a flow reduction. These are some of the procedures considered for flow reduction. One is banding, the another one is distal revascularization with interval ligation. Next is PAI, proximalization of the arterial inflow, and ultimately which the patient underwent was RUDI, revision using distal inflow. In this, we primarily ligate the fistula which was initially made, the anastomosis which was initially made is ligated, and one of the distal arteries is used for arterial inflow. The goal is to reduce the blood inflow, arterial inflow into the fistula vein, and thereby decreasing the symptoms of high flow. Or some cases we do RUDI for Steele syndrome also, for like diabetic patients who have a syndrome in the distal part of the hand. So after RUDI, they're expected to improve. So the current status of this patient, you can see the extreme left image shows the fistula with the patent vein, and the next picture shows there is extensive collateralization, and the last third picture shows the patient has dilated veins. What you see here is ulnar a basilic vein, sorry. What you see here is basilic vein. So ultimately the blood flow from the cephalic vein is redirected into the lateral channels, and which goes till the wrist joint of the patient, and the blood flow is again coming back through the basilic system of the patient. So the access for the patient is taken, the arterial access is taken near the fistula, and the venous return is given via this basilic system. So further plan of this patient would be irrespective of, in spite of the patient getting fistula reduction surgery done, if she develops symptoms of cardiac overload, then we can plan. There are few options. One of which can be ligation of BCF, brachiocephalic vein, and we can make a ulnobasilic vein. But still, it would be a risk for this patient, because every time all three procedures which she underwent under general anesthesia. So taking up the child in GA under every situation is not easy. One more option can be the patient has multiple collaterals, so we can choose one proper collateral which is adequately dilated and used for dialysis, and ligate all other collaterals so that patient can maintain a single vein for cannulation. Thank you.
Thank you, Dr. Vanji. And now coming back to the disease course, latest in July 22, the patient was admitted with us again. This time with the complaints of chest pain for 15 days and low-grade fever for 7 days. There was no history of cough, breathing difficulty or exertional dyspnea. The examination revealed tachypnea with pallor. The left arm veins were again tortuous and dilated. Bilateral crepitations were there, and the S1, S2 was loud when the patient had hepatomegaly. So a diagnosis of pneumonia was made, and she was started on antibiotics, and for fluid overload she was started on maintenance hemodialysis that she was already undergoing but had missed a session. So while admitted, she had an event of mucositis and along with pancytopenia, and there was also a rash, again a generalized maculopapular rash. The workup revealed decreased C3 and ANA, which was this time 2 to 3 plus homogeneous, and the anti-dsDNA done was positive. A skin biopsy was done which revealed hyperkeratosis and focal parakeratosis. There was edema in the upper dermis and minimal perivascular lymphocytic infiltrates. The immunofluorescence for the skin biopsy done at this time again was negative. So a possibility of lupus was considered, and the patient was started on steroids. So to tell about this, I would like to invite Dr. Anubha from the Department of Dermatology.
Good morning, everyone. So I would be just stressing on the cutaneous manifestations that were seen in this child when we first received the call. So when we first got the call, the patient had 3 different distinct morphologies in the mucocutaneous area. So the first was oral mucositis. So the child had this kind of a presentation. So there were diffuse erosions all over the oral mucosa, and that was covered with a whitish kind of a slough, and there was minimal involvement of the lips. There was no hemorrhagic crusting seen, only mild cheilitis was present. So apart from that, the patient also had this kind of a hyperpigmented rash over the trunks, so patchy hyperpigmentation over the trunks and the proximal upper limbs as well. So we mostly, and on blanching the skin, there was still some amount of residual erythema that was seen. So we made this out to be a resolving kind of a maculopapular rash, and the patient also gave history of a rash in 2020 as well. But the rash was not that distinct at this point of time. It was mostly in the resolving phase. The third morphology that we saw in this patient was in the palms and soles. So we saw that it's not very clear in the picture, sorry. So we saw this kind of pinpoint petechial macules that were seen over the tips of the toes and other areas of the soles as well. And these lesions were also somewhat resolving with hyperpigmentation when we saw the patient. So we made this out to be vasculitic lesions. This pinpoint petechial macules is very characteristic of leukocytoclastic vasculitis that is seen in many of the connective tissue disorders. So, and apart from that, there was also reduced growth of hair and increased hair loss that was reported by the parents. So based on all these findings, I would just like to stress on the cutaneous manifestations of lupus erythematosus. So a good reference point is to refer to this Gilliam classification of cutaneous lupus that has acute lupus, subacute cutaneous lupus, and chronic cutaneous lupus. So coming to the acute cutaneous lupus, this is the very characteristic lesion that we always see is the malar rash sparing the nasolabial folds. However, it was not seen in this index patient. And the patient probably had this maculopapular rash. Now in Indian skin, it is sometimes very difficult to appreciate maculopapular rash because of the darker color of the skin. So a good reference point would be to slightly blanch the skin using your fingers, and then you will be able to appreciate the erythema when it comes back. So that was positive in this index patient. Apart from this, a SJS10-like manifestation can also be seen. And this is a very characteristic classical lesion of subacute cutaneous lupus, where you see these annular, scaly kind of plaques over the trunk. And this is a characteristic discoid lupus erythematosus lesion. They'll be mostly isolated lesions with a central hypopigmentation and peripheral hyperpigmentation along with scarring. And this is a disseminated discoid lupus erythematosus rash. So coming to this this index patient, it was mostly fitting into acute rash of acute cutaneous lupus, which is the maculopapular rash kind. So lupus erythematosus can present with both systemic and skin disease, and there can be various permutations and combinations and courses that can be possible. With the 3 different types of LE can occur along with SLE in various forms. Both systemic disease can be present standalone, it can be present with skin lesion, which can occur both in the initial course or later in the course of the disease. So apart from the LE specific lesions, we also have a lot of non-specific cutaneous lesions that can occur with LE. So in this patient, what was striking, this is not pictures, this is just for reference, these pinpoint petechial lesions that are commonly seen in palms and soles, along with a palpable purpuric lesion in the lower limb also can often be, it's very commonly seen in patients of LE. So this is, I just put this picture for reference. This is a picture of lupus hair. It is very commonly seen in most of our pediatric patients also. So they'll have this short stubby kind of hair at the hairline along with reduced growth and easy breakability. So in 2020 also the patient gave history of some rash. I'm not sure if we had seen the patient that time or not, and records were not available, but a biopsy was done from the rash, which showed epidermal thinning, flattening of the rete along with occasional apoptotic keratinocytes. So there is some kind of an epidermal atrophy going on along with some interface changes. There was focal basal cell vacuolization as well, but there was no thickening of basement membrane. Now, thickening of basement membrane is seen more in the chronic cutaneous LE and subacute cutaneous LE spectrum, less commonly seen in the acute. And there was some perivascular periadenic cell infiltrate in the dermis, which was non-specific. However, the PAS stain and the Alshan blue stain highlighted mild increase in dermal mucin. Now, this is very specific finding for connective tissue disorders, both lupus and dermatomyositis. So, in this case, it fits more with lupus. So this is a very good differentiating point from maculopapular rash related to CTDs and DRESS or other drug rashes. So when we saw the patient now in August also, we again performed a skin biopsy from the lesions over the toes. However, this only showed hyperkeratosis, focal parakeratosis, mild edema in the upper dermis along with minimal perivascular lymphocytic infiltrate. And no interface changes were seen and even DIF was negative. So the reason we did not get much yield out of this biopsy was probably because of the timing of the biopsy. It was performed late in the course of the disease when the rash was already resolving. So just one point about lupus band test. So it is basically the deposition of immunoglobulins and complement in the skin at the basement membrane zone. And when 3 or more immunoreactants are present in the non-lesional photoprotected skin in patients of LE, the diagnostic specificity and sensitivity for LE is very high. So, however, DIF was negative in this index patient, probably, as I already mentioned, because of the timing of the biopsy. So, another possibility candidiasis. Now, oral candidiasis is the top picture on the right. Basically presents with these curdy white or creamy patches that are stuck onto the wall of the oral mucosa, and when you wipe it off with a gauze, it can easily be wiped off. However, ulcers of LE will be mostly present as erythematous, shallow erosions, and sometimes it will be covered with the white slough. Now, they can be localized also, and they can be generalized, covering the entire mucosal surface, as was seen in our patient. And this picture is a picture of a DLE oral lesion, which has the central scarring and peripheral radiating whitish striae. So how do we differentiate maculopapular rash of lupus from drug rash and DRESS? So there can be no history of photosensitivity present in patients of drug rash. Facial involvement is seen in DRESS as well, but more in form of facial edema rather than a rash. And purpuric lesions and palmoplantar vasculitic lesions are relatively absent in patients of drug rash or DRESS. Leukocytoclastic vasculitis can be seen in DRESS as well, but it is extremely rare. And in histopathology, interface changes also can be seen in drug rash, but no mucin will be seen, no epidermal atrophy will be seen. And eosinophils is again a clinching point for diagnosis because it will be a predominantly eosinophilic infiltrate in the dermis. Again, lupus band test will be negative, and systemic involvement will occur much later after the onset of rash, like nephritis, hepatitis, encephalitis. All this can also occur in dress, myocarditis, but they will occur after the rash is presented, and not unlike in this patient where patient already has systemic involvement and then presented with rash later on. So this combination of mucositis, maculopapular rash, and probably leukocytoclastic vasculitis, which we did not get on biopsy, you can point towards three things: either a viral exanthem, or a drug rash or dress, or acute cutaneous LE. So considering the other systemic other features which were present, like diffuse hair fall, along with ANA positivity, along with systemic manifestations, both in the past as well as concurrently, it fits better with acute cutaneous LE. And it is mucositis also raises the possibility of oral candidiasis. However, KOH was done in this patient and it was found to be negative. So there was no secondary infection with oral candidiasis as well. It was just plain mucositis of acute LE.
Now I would like to invite Dr. Sanjeev.
Good morning all. So I would like to start from the beginning. So we had a 9-year-old girl child who presented with fever, vomiting, breathing difficulty, reduced urine output for 7 days in 2019. At presentation she had pancytopenia, uremia, bilateral small shrunken kidney, serositis, ANA 2+ speckle pattern, low C3 with normal C4, and bone marrow myelofibrosis. Now the question is that at that time the child has lupus or not. So at that time several points was in favor of lupus, such as girl child of 9 years, fever, pancytopenia, positive ANA, and low C3. However, there are multiple points against the diagnosis of lupus at that point. No constitutional symptoms, short duration of presentation, no classical cutaneous features, alopecia, oral ulcer, myelofibrosis in the index child, small shrunken kidney, and ANA 2+ speckled pattern that is also found in the 5% normal population. So what happened in between 2019 and 2022 in follow-up? Child had several episodes of intermittent fever that was treated with antimicrobials. However, she didn't have any mucocutaneous and musculoskeletal features. She required multiple PRBC transfusion for severe anemia that was attributed to CKD, but we are not sure whether it was due to autoimmune hemolytic anemia or not. She had persistent thrombocytopenia in follow-up that was attributed to heparin-induced thrombocytopenia, maybe due to lupus also. And in the meantime, her ANA turned out to be homogeneous pattern from speckle pattern. She had raised anti-DSDNA titer, low C3 level. And in 2021, she had one episode of fever with skin rash. In presence of lymphopenia and thrombocytopenia, the child was diagnosed to have multisystemic inflammatory syndrome and treated with IVIG and steroid. So we are not sure whether at that time the diagnosis of lupus was there or not. But one thing is against lupus that most of the Auxin child responded without steroid. That is against the diagnosis of lupus at that time. Presently in 2022, the call given for persistent fever for 18 days, blackish maculopapular rash over trunk, face and ear lobule, oral thrush and pancytopenia in the index child. On examination, she was found to have stunted and wasted. Her BP was controlled on multiple antihypertensive. She had severe pallor. She had blackish macular rash over abdomen, chest, back, face and ear lobules. She had also features of pneumonia in the form of bilateral capitation and tachypnea. And also she had hepatosplenomegaly. Initial investigation revealed pancytopenia, raised CRP with procalcitonin. On peripheral blood smear, she had macrocytes and cystocytes. She had hyperferritemia that was attributed to CKD and mild transaminitis and positive homogeneous ANA. So initial consideration was, is it flare of SLE or the child is having autoimmune hemolytic anemia in the background of SLE, and also the child is having macrophage activation syndrome or not. So battery of investigation was advised to confirm the diagnosis of lupus, autoimmune hemolytic anemia, as well as macrophage activation syndrome in the index child. And the child was prescribed to continue antibiotics and hemodialysis, and she was initiated on oral prednisolone and sunscreen. Further on investigation revealed severe anemia with thrombocytopenia, lymphopenia, increased CRP and procalcitonin. DCT was positive. Peripheral blood smear showed teardrop cells with macrocytes. LDH was high. Serum ferritin was sky high in the tune of 16,000. Anti-DSDNA titer was positive. C3 was low, however C4 was normal. Skin biopsy in this admission showed epidermal keratosis with focal parakeratosis. However, DIF was negative. So our diagnosis was systemic lupus in the index child with minor organ involvement, cutaneous and hematological, in the form of thrombocytopenia and autoimmune hemolytic anemia. However, it is not sure whether it is drug-induced lupus or not. And also the child had myelofibrosis that may be related to lupus or also CKD, and macrophage activation syndrome. It may be either infection triggered or related to lupus. So after 7 days of starting immunosuppression, the child became afebrile, skin color changed, the oral mucositis disappeared, hepatosplenomegaly reduced, cytopenia improved, and ferritis dropped down from 16,000 to 2,000. So point for discussion from pediatric rheumatology perspective is, was the child had lupus at beginning, or the lupus evolved over the time in the index child? Second thing is the macrophage activation syndrome in lupus. And could it be the drug-induced lupus in the index child? And finally, the management of lupus in the index child. So if we, initially we have a diagnostic dilemma regarding the lupus, whether the child had lupus in 2019. So if we go through the different classification criteria, we can see, according to SLIC 2012 criteria, at least 4 criteria should be positive out of the 17, at least 1 each from group. So index child had 6 point positive, so most likely as lupus. Again, if we go through 2019 ACR regular criteria, child met the must criteria, entry criteria, ANA was positive. And also she was scored to have 15, that is more than 10, and that is suggestive of lupus. But now the question is, at the presentation, the CKD was related to lupus or not. So if we go through the literature on renal manifestations of lupus, we can see that renal manifestations are more common in children in comparison to the adults. And around 70% children present with renal involvement within the first year of diagnosis. And usually we note the urinary sediments, cast, hematuria, and proteinuria during active proliferative glomerulonephritis. And one child with lupus presenting a CKD is very unusual. Around 10 to 20% patients develop end-stage renal disease or CKD after mean duration of 5 to 7 years. However, in the index child, the child had acute presentation, no phenotypic features and constitutional symptoms for lupus. She had no cast, sediments, and hematuria on previous urine reports. So the CKD in the initial presentation in the index child unlikely to be due to lupus. However, ANA immunoblot or renal biopsy at the time of presentation can confirm or exclude the possibility of lupus. So on regarding the hematological manifestation, anemia, thrombocytopenia, and leukopenia is the most common. In addition, thrombosis may be present in APLA-positive patient. The index child has anemia, leukopenia, and thrombocytopenia in most of the time throughout the last 3 years. In addition, she required multiple blood transfusion in last 3 years. It may be due to related to autoimmune hemolytic anemia, we are not sure. However, the ANA immunoblot, reticulocyte count, and LDH in the previous admission could confirm or exclude the diagnosis of lupus in the index child. Now coming to the macrophage activation syndrome in childhood lupus. Macrophage activation syndrome is seen in 9% patients of the childhood lupus patient, and it is mostly under-recognized, and it is with high mortality rate of 13%. The index child has organomegaly. She had hyperferritinemia, rising trend of ferritin from 2,000 to 16,000. She had raised triglyceride, mild transaminitis, and also the ferritin dropped with steroid. So the child had macrophage activation syndrome, no doubt. However, it was related to infection triggered or it was related to lupus, we are not sure. So when we extrapolated our data from our unit, around 2% children of lupus had macrophage activation syndrome. And most of the children treated with high dose of steroid even after they died. But in the index child, the child was treated with low dose of steroid and she responded. So most likely the index child has infection triggered macrophage activation syndrome. So initially the child had speckled pattern of ANA 2+ that may be found in the normal population also. The characteristic feature is in lupus is homogeneous pattern. So over the time the ANA turned out homogeneous from speckled pattern. So the question is that is the child has developed drug-induced lupus or has the classical lupus from the initial part. So drug-induced lupus is a lupus-like syndrome temporarily related to continuous drug exposure, and it resolves after discontinuation of the drug. There are currently no standard diagnostic criteria for the drug-induced lupus. There is a long list of drugs that causing lupus, out of which the index child was exposed to many drugs like clonidine, labetalol, and minoxidil and pyrazine for reasonable time period. There is a certain difference between the classical lupus and drug-induced lupus, mostly in the disease severity, the antibody profile, and treatment response. In drug-induced lupus, the disease severity is less in comparison to the classical lupus. And mostly patients are associated with antihistone antibody, and they respond nicely with the omission of the offending drug. So in the index child, she had drug exposure for reasonable time duration with multiple drugs. She presently has a confirmed case of lupus based on the serology and clinical phenotype. However, in drug-induced lupus, usually they have hepatitis, and the skin lesions are like subacute cutaneous lupus. So the ANA immunoblast can confirm our diagnosis of drug-induced lupus. Regarding the management, the child with lupus requires immunosuppression. The dose depends on the major organ or minor organ involvement. In cases of minor organ involvement, the dose of steroid are low. So in this child was started on oral prednisolone. And sun protective measures are also very important for the management as well as to prevent the flare of the disease. So the child was started on sunscreen and as well as hydroxychloroquine. And our plan was to start immunomodulator like azathioprine instead of steroid in follow-up. And also in follow-up, if the child turns out to be antihistone antibody positive, we will try to stop the offending drug and see the response. And also child was recommended to continue the hemodialysis and supportive measure. And also importantly that this child required renal transplant in future. Thank you.
Thank you, Dr. Sanjeev and Dr. Anuba. Now, after all that, we had now clinical diagnosis and a diagnosis of chronic kidney disease stage 5 hemodialysis dependent, with etiology most likely being Charcot and the patient having drug-induced lupus with complications of growth failure, hypertension, anemia, mineral bone disorder, and metabolic acidosis. So just a word about CKD progression. Whatever damage to the kidney has been done, but we have to salvage whatever the kidney function is left. And to do that, we have to look at the progression of CKD. And there are multiple factors that are implicated in the progression, like elevated BP, high level of proteinuria, hypoalbuminemia, metabolic acidosis, dyslipidemia, hyperphosphatemia, and persistent anemia. Of these, the elevated blood pressure and a high level of proteinuria, they have shown to have an impact on the progression of CKD in children. So at every visit, we have to make sure that the patient has a BP around 50th centile, and we have to reduce the level of proteinuria to as low as possible. And about the immunizations of the child should be updated as early as possible with all the vaccines that are available as per the schedule. And additional vaccines, the patient needs to get varicella vaccination, annual influenza vaccination, and pneumococcal vaccination every 5 years. And the dietary modifications are very important because this is, as I already discussed, that the patient is having poor nutrition and poor appetite. So we have to make sure that the energy that the patient is taking, the calories, is towards the higher end of the suggested dietary intake. And the target protein intake, it should be also at the upper end of the SDI, suggested dietary intake. And with a patient who is undergoing peritoneal dialysis needs extra 0.1 to 0.3 gram per kg per day of proteins. And HD dependent patient need around 0.1 gram per kg per day extra. If we think that if we see that the patient is having high urea despite everything, then we have to optimize the RRT, and post that we can think of decreasing the intake. And for the infants, breastfeeding is the preferred method. And if needed, we can fortify the breast milk or infant formula, whatever the child is taking. And if the oral acceptance is not adequate, then we may need to give enteral tube feeding, either supplementary or exclusively to the child, because nutrition in CKD is very important. So the plan in index child is optimal medical management, which she is getting, maintenance hemodialysis around 3 times a week, 4-hour session, and we have to optimize the access for HD as already discussed by Dr. Vanji, and to watch for disease activity. And finally, transplant. The child is currently registered in the transplant registry for cadaveric kidney transplant.
You can, in the meanwhile, junior residents, please, I think you should be having a lot of queries in this case.
Ma'am, initially the child had ANA 2+ speckled pattern. Normally the ANA